It's a hello, good afternoon to COVID scientists and warriors. A warm welcome to all the speakers and participants. I am Dr. Subhash, Hira, moderator of the webinar learning series that is launched by the Global COVID-19 Network. As COVID scientists and warriors are drowning in tons of information through publications and social media, the scientific webinars are becoming more credible sources of reliable information. Sambodhi Research and Communication Organization, Indian Social Responsibility Network, New Delhi, and the University of Washington, Seattle have co-sponsored this global network to foster South and South collaboration and partnership to share lessons of COVID. As of 26 May 2020, that's today, the cumulative world case count of COVID has recorded over 5.5 million people infected, and just over 350,000 have lost their lives, thus giving us a fatality rate of 6.5%. I will be very brief to recap the fourth webinar that was held last week on the 19th of May. The clinical diseases they were described that were caused due to COVID, and it occurred in about 15 to 20% of infected persons in different countries, and occur in three stages. Primarily the viral responses in terms of fevers and sneezing and cough, the lung stage, which leads to breathlessness and a low oxygenation of blood, and the storm in the vital organs of the body that cause shutdown of the vital organs at time and cause a lot of clotting. Dr. Prashant Saxena of MaxSmart, Saket, he discussed the effectiveness of the various approved treatments and drugs being currently utilized in the treatment of patients. No cases of relapse or reinfection were reported from India so far. Dr. Debashish Gupta of Sri Chitra Medical Institute was the first one to introduce convalescent plasma therapy in the state of Kerala. He saw positive initial responses in using convalescent plasma therapy in treating 4 patients with severe cases of severe disease of COVID. And finally, Dr. Marcus Jr., he shared a realistic timeline of 12 to 18 months for COVID vaccines, but he had several concerns pertaining to the effectiveness of vaccines. He spoke about the importance of studying the correlates of immunity, and that would obviously take time. Today's webinar is titled Personal and Institutional Prevention and Protection Against COVID. I wish to explain this slide that shows use of facial mask. The mask sounds fairly simple, but it requires common sense for its effective use. Let's look at the bottom of this slide, wherein you find a person at home is safe from COVID infection even when the community around is infected and outside they don't wear a mask. A little above, you will find that the community wearing mask properly that covers the nose as well as the mouth and keeps distance of 6 feet away from other individuals, which is called the physical distancing, will have likelihood of low infection transmission of 2 to 3%. As we go up, we see that as the community people do not put on mask and are not maintaining the physical distancing, the transmission rate of COVID can become very high, say up to 33%, even when the infected persons may or may not be wearing a mask. To sum up this slide, it provides 6 different scenarios of a simple use of mask where the individuals versus the infected people in the communities might be wearing the masks differently, alternatively, and that would reduce or increase the chance of transmission. Moreover, you don't need to wear a medical mask. Instead, a cotton mask made at home can be a good protection when it is used properly. So it's not just to say that. So it's Dr. Daniel, it's up to you to please take it over.
Greetings to you all, and thanks for inviting me. Italy was the first European country to halt all traffic with China by plane and declare a state of emergency on January 31st, while even putting scanners in airports to check arrivals, since we are now aware that the virus had been circulating in Italy since early January, if not before. Doctors dealing with pneumonia in January and until mid-February were unaware it was the coronavirus, since the symptoms were so similar to influenza, and the coronavirus was still believed to be largely confined to China. Even after Italy documented its February 21st cluster cases, the unusual way COVID-19 could present itself was understood, with some patients rapidly declining to breathing insufficiency. This comes as no surprise, since Italy was the first European country facing the explosion of the COVID-19 crisis. In this context, it was the first country in Europe to impose restrictions when coronavirus cases began to surface in its northern regions in February. By the beginning of March, the virus had spread to all regions of Italy, though with lesser extent and intensity in central and southern regions than in northern ones. Under these circumstances, Italy was the first country to implement a national quarantine as a result of the dizzying increase and spread of coronavirus cases. On 8 March, Italy confirmed an additional 1,492 cases and 133 deaths, taking it to a total of 7,375 cases and 366 deaths. On 9 March, the government of Italy under Prime Minister Giuseppe Conte imposed a nationwide quarantine restricting the movement of the population except for necessity, work, and health circumstances in response to the growing pandemic of COVID-19 in the country. Additional lockdown restrictions mandate the temporary closures of non-essential shops and businesses. In sum, the quarantine spanned between March 9 and May 18, and the methods were the ban of non-essential travel, limitation of free movement except in cases of necessity, as said, ban of public events, closure of commercial and retail businesses except essential goods, sellers, and banks, suspension of teaching in school and universities, under surveillance quarantine of infected persons, shutdown of all non-essential businesses and industries. Regardless, strict observance of nationwide quarantine measures, hot epidemic days went on, and on 27 March, Italy confirmed a new high single-day death toll with 919 deaths, increasing the country's total to 9,134. Overall, confirmed cases of infection rose to 86,498. No doubt that Italy has delayed taking some drastic decisions along COVID outbreak and made some operational mistakes. Let me remember here that the outbreak came to light when a 30-year-old Italian tested positive in Codogno, a municipality in the province of Lombardy, in the Lombardy region. On 14 February, these people felt unwell and was prescribed treatments for influenza. On 16 February, as the man's condition worsened, he went to Codogno Hospital, reporting respiratory problems. Initially, there was no suspicion of COVID-19, and no additional precautionary measures were taken, so allowing the virus to spread undisturbed and infect a number of other patients and health workers as a ripple effect. While the fault mentioned above partly arises from being Italy the first European country to be ravaged by the epidemic, at least a couple of further deaths happened during epidemic most hot days in Lombardy. Firstly, because Lombardy's intensive care units were already filling up within days of Italy's first cases, many primary care physicians tried to treat and monitor patients at home. Some put them on supplemental oxygen, commonly used for home cases in Italy. The strategy proved unfortunately deadly, and many died at home or soon after hospitalization, having waited too long to call an ambulance. Secondly, a 3rd March regional decree aimed at easing pressure on Lombardy's ICUs, told nursing home directors to not hospitalize sick residents over 75 if they had other health problems. The decree said it was opportune to treat them in the same facility to avoid the further risks of decline in transport or during the wait in the emergency room. The decree also entitled properly equipped nursing homes as suitable isolation places for COVID patients discharged from hospitals. As for the elderly at some nursing homes, the decree unfortunately amounted to a death warrant. Notwithstanding the mistakes highlighted, Italy has anyway provided global policymakers with good practices to follow. In this regard, as reported in newspaper Forbes on April 14th, 6 good practices can be highlighted in Italy's response to the coronavirus. As per Otte's terms, these practices would include 1. Prioritize citizens' health and well-being. This point concerns the priority given by the Italian government and Italian institutions to citizens' health and well-being. 2. Emphasize transparent communication. Italian leading figures have preferred to convey clear messages about the extreme seriousness of the situation. In this context, Italian institutions have also done extra work to control and neutralize the spread of false information, which can so easily run throughout social media. 3. Focus on flexibility and taking an integrated approach, meaning that organizations that generally work in sector and contexts that are very distant from each other have integrated their operational capabilities to deliver important tools and machines to fight against COVID-19. For example, Italian CR Engineering International Group, one of the 4 companies in the world producing lung ventilators, has integrated into its organization a team of military engineers in order to guarantee 24-hour production. There are several other similar examples in the country, including the operational integration between the Italian Civil Protection Department and local volunteers associations, and the case of small factories producing protection masks and police force distributing them, among others. Another example worth mentioning is the Italian fashion sector. Companies like Valentino, Calzedonia, Geox, and Prada have quickly moved to the production of masks and other material useful to our sanitary professionals and the population at large. It is interesting to note that the Italian reaction has been neither top-down nor bottom-up. It has instead proved to be an effort of spontaneous, reciprocal collaboration between actors of any kind at any level who are willing to cooperate in new innovative ways. The rapid development of an effective emergency logistical system. Italy has very rapidly developed infrastructures, for example, the development of ad hoc COVID hospitals throughout the country and emergency transportation system. This complex effort also has involved the coordination between military and civil institutions, in particular for the carriage of people in extreme situations. 5. an emphasis on professional responsibility. A systemic culture of professional responsibility in critical professions such as nurses, medical doctors, public servants, etc., has allowed the Italian system to increase the number of professionals fighting against COVID, as it was the case during most hot epidemic days for the Italian civil protection launch of a call requesting the help of 500 volunteer nurses. In less than 48 hours, it received over 9,500 applications. 6, urge a coordinated international response. During the first and second week of February, the Italian Minister of Public Health, Roberto Speranza, worked hard to organize the first extraordinary assembly between all health ministers of the European Union. During the meeting in Brussels on February 13, the Italian government expressed the need for all European countries to approach the COVID crisis in an integrated way and to take into serious consideration also the African situation. In conclusion, I would like to remark Italy's clear strategic priorities, wherein citizens' health and right of information have been put at the top of the national agenda. When it comes to today's situation, the Italian government began to relax lockdown measures earlier this month when it allowed factories and parks to reopen on 4 May. Italian cabinet's announcements came shortly after the country, which was once the global epicenter of the pandemic, reported a further decline in its daily death toll. While Italy reported more than 900 deaths on 27 March, its daily death toll is around or below 100, now that the number of new cases keeps decreasing. In this connection, let's have a look at the latest figures released by the National Civil Protection Department. As of 25 May, the total number of infected persons was 230,158, leading the total of still positive cases to 55,300, resulting in a decrease of 1,294 cases compared to the day before. The number of patients in ICUs was 541, recording a decrease of 12 patients compared to the day before. 8,185 people were hospitalized with symptoms, a decrease of 428 compared to the day before. For 6,574 people, equal to 84% of all infected cases, were in isolation without symptoms or with mild symptoms. 92 new victims were reported, bringing the national death toll to 32,877. The total number of discharged patients who have recovered from the virus rose to 141,981, an increase of 1,500 people compared to the day before. Therefore, and in alignment with current lockdown easing under government decision, shops and restaurants reopened from 18 May, providing social distancing is enforced. Catholic churches started resuming religious services en mass on the same day under strict social distancing, with worshippers wearing face masks. Other faiths are also allowed to hold religious services. Mr. Conte announced the travel to and from Italy and between the country's regions will be allowed from 3 June, whereby travelers from EU countries will be able to enter Italy without going into a 2-week quarantine. Gyms, swimming pools, and sports centers reopen on 25 May, while cinemas and the theaters have to wait until 15 June. In sum, the announced measures are a key step in the country's effort to restart its economy after more than 2 months of lockdown. On May 13, the Italian government released a so-called relaunch decree containing financial measures worth 55 billion euros, that is 59.6 billion US dollars, to support the economy hard hit by the pandemic. As part of that decree, the National Health Service has been allocated 3.25 billion euros, meaning a much higher figure than what a state usually invests in the National Health Service in a whole year. Health service investment was specifically earmarked to regional network, stronger hospital network, and health personnel recruitment. In detail, as for regional network, major financial resources will be invested in reinforcing the regional network as the more reliable bulwark to count on in epidemic course like the current pandemic. As per Health Minister Speranza terms, we are putting 9,600 nurses out on the field with a figure of family nurse, and we are investing in particular in home services for fragile people, which will lift the percentage of people receiving care from 4% to 6 and 7%. As for stronger hospital network, a big chunk of the financial resources will be used to strengthen the hospital network, aiming to gain up to 11,109 places in intensive care, 115% more than we had before the COVID emergency. This grounds on the rationale that we don't know what is in store for us. The experts have spoken of the possibility of a second wave of contagion. We must be ready. Finally, as for recruitment, on the same wavelength, Minister Speranza also announced that another 240 million euros will be invested in the recruitment of new personnel, and 190 will go on incentive for doctors, including by financing, another 4,200 specialization bursary. Coherently with this mandate, Minister Speranza also told World Health Assembly last week that COVID-19 vaccine must be a global public good, a right for all. Thanks for your attention. While wishing to close my presentation with a couple of links to stay updated with day-by-day COVID situation in Italy and national government relevant decisions. These links refer to the official site of the Minister for Health, Italian Minister for Health, and with the site of the National Civil Protection Department. Thank you.
Thank you, Dr. Daniel. Thank you for an excellent presentation. I think we'll move on with the second speaker, Dr. Leena Inamdar. She's a consultant epidemiologist with the National Health Service in England, in Leeds. And she's going to speak about the protection at personal and institutional level for individuals as well as institutions against COVID. So, Dr. Inamdar, it's over to you.
Hello, everyone. My name is Leena Inamdar. As Dr. Hira mentioned, I'm a public health physician currently working in global health for health system strengthening in low and middle income countries, and currently working on a international health strengthening regulations program at Public Health England. My talk represents my personal views based on international evidence and not of my organization. I've been invited to talk on personal and institutional prevention and protection measures. So at the outset, I would like to highlight that different countries are currently in different phases of the pandemic response. So everyone should follow their own country national current guidelines. What I will aim to do in my presentation is to cover the main principles in terms of prevention and protection measures, but each country has developed its own guidance based on how the epidemic is progressing in their country, its population and systems. So it's necessary we follow our own national guidance. I just wanted to highlight at the moment with this slide how the world, we are all currently facing a battle against the unknown and invisible enemy. And this enemy does not respect any border or hierarchy. And unfortunately, it has exposed tremendous fragilities in our systems, whether we're talking of developing countries or developed countries. Since a large proportion of the audience is from Global South, just to highlight key issues which are common to the Global South during the COVID-19 response. Now, first wave of the COVID-19 pandemic, it may be receding in some parts of Western Europe, East Asia, or North America, but it is rapidly taking off in Latin America, Africa, and South Asia. And some of the countries in these low middle income country regions are experiencing spiraling infections, hospitalizations, and deaths. Owing to a lack of testing, it is likely that the numbers may be quite an underrepresentation of the true numbers. And the impact of COVID-19 doesn't just depend on the national preparedness, but it also depends on the state of readiness of our states and municipal corporations as well. Now, what cities like in Brazil, in Nigeria, and in India do next will not only determine the health of their residents, but in fact, it will also impact the fate of their national economies in future. And whether rich or poor, all cities are facing similar challenges as COVID-19 spreads, especially the way it impacts our underserviced populations. Many cities have experienced shortfalls in testing kits, in protective gears and medical equipments. Hospitals, clinics, ICUs are limited. So cities in these developing countries really have a triple burden, and that includes low health capacity, stark socioeconomic disparities, and also high population density that make the physical distancing measures, the shelters in place, almost virtually impossible, quite challenging to adhere to and to enforce as well. I'm going to give an overview of the prevention and protection levels at personal, institutional, and workplace level. As different world regions are now in different phases of the pandemic response, it is critical that there is clear guidance to the public, to health professionals, and to workplace employers to prevent illness and protect our citizens. And it is really imperative that everyone plays their part in fighting COVID-19, whether it is at a personal level, at an institutional or societal level. Now, in my talk, I will cover prevention and protection at the personal and institutional level, including workplaces. This will include, to a certain extent, measures at societal level. However, there is a lot more that we need to do collectively as a society to tackle COVID-19, and especially protecting the most vulnerable and deprived populations of our communities. That itself is a topic on its own, and I will not go into detail into this today. As we all know, the transmission of COVID-19 is thought to occur mainly through respiratory droplets and generated by coughing and sneezing and through contact with contaminated surfaces. So it is key that the prevention measures are mainly centered around interrupting transmission through these routes by breaking the chain of transmission. So let me begin with measures at a personal level. We all need to think about what is it that as an individual we can do to play our part in this fight. So measures to protect yourself and others. There are three key areas that we need to pay attention to for protecting ourselves, our family, and those around us in the wider community. And these measures are, we all know about the social distancing measures. So I'm not going to repeat all of them, but it's really important to try and minimize contact outside our home as much as possible. If people develop symptoms, they need to immediately self-isolate for at least 7 days or until they recover. And the key thing is to protect the clinically vulnerable people, because we know there are some population groups in our societies that are at more risk of severe disease from COVID-19. So we need to protect them the most. And we need to maintain the social distance when we go out. We need to pay particular attention to the personal and protective measures and hygiene measures. So that includes obviously having a good respiratory hygiene, hand hygiene, and making sure that there are obviously, um, certain guidelines which each country will obviously issue for their own national sort of citizens. But we need to adhere to these and make sure that we wash our hands regularly, at least for 20 seconds with soap and water, or use hand sanitizer when that is not possible. The other thing is to consider use of face coverings in enclosed spaces where social distancing isn't possible. And we will touch upon that in a minute. And the last measures are environmental measures. So basically frequently cleaning the surfaces which are common contact surfaces, minimizing sharing objects with others, and ensuring there's adequate ventilation in enclosed spaces. So I just wanted to highlight and signpost some of the resources that are available freely for everybody on the WHO websites, which also include measures in terms of advice in terms of how you protect yourself, how you protect others from getting sick, what to do if I am going to the grocery shop, and how do I keep myself and others safe, and how do I greet others if I do have to go out, what etiquette should I follow. So just a quick note on face coverings. Dr. Hira has already mentioned this at the very start of his presentation. In some countries, masks or face coverings are worn as part of local customs or advice by national authorities in the current context of COVID-19. And in this situation, it's best to follow whatever best practices are given by our national authorities on how to wear, remove, and dispose or reuse cloth face coverings. And it's also very important to practice good hygiene before and after removal. I think I would really like to stress that face coverings do not replace social distancing measures. So we all need to practice all of the advice in addition to considering use of face coverings when we think that we will be in a position where social distancing may not be able to be adhered to. And in decision making on advice on face coverings for the community, there are some key considerations that we all need to be aware of that governments have had to take into account when issuing advice. What is the purpose of wearing a face covering in the in the community for the public? Is it for source control, that is for infected people, or is it for prevention, that is for healthy persons? What's the risk of exposure in our current context in the local economy? So that is dependent on the epidemic in each country, in each local setting, and how it is progressing. What's the vulnerability of the population groups? Are there certain groups more susceptible? Also the settings, what's the population density like? In some crowded areas, it's impossible often to maintain that social distancing. So then that may be a consideration. The feasibility, of course, the availability, the cost and tolerability of individuals, and then the type of coverings, like whether we are talking of medical or non-medical masks. So these decisions have to be taken into account based on these key considerations. I will now move on to the institutional and workplace measures. And for the purpose of this presentation, I have categorized this as measures in health and social care settings, in workplace and industry, educational settings focusing on schools, and public transport operators. Now, we know that the way COVID-19 has affected workplaces is increased absenteeism, change in the pattern of commerce, and interrupted supply and delivery. And based on the pandemic phases, as countries are reviewing their lockdown measures and developing recovery plans and roadmaps to opening the economy, there are several considerations to take into account as we aim to get the workforce back into workplaces at the appropriate time. So what you can see here is the occupational risk pyramid for COVID-19. Now, this slide shows 4 categories of risk, which are very high, high, medium, or lower risk. Now, very high risk is mainly for healthcare workers who will come into contact with known or suspected COVID-19 cases. The high risk is for those who are in delivery and support functions who will also come into contact with known or suspected COVID-19 cases. The medium risk workers are those who are key workers who are obviously essential to maintain our economies, but they are likely to be in contact with possibly infected cases who are not yet known or confirmed. And the lower risk occupations, where it is unlikely that there's minimal occupational risk, perhaps solo workers who are unlikely to be in contact with other known or infected cases, or indeed other people. this slide I wanted to show because this is a thread that is going through the presentation in terms of hierarchy of control measures. And this is the fundamental method of protecting workers. Now, traditionally, hierarchy of controls has been used as a method to determine how to implement feasible and effective control solutions. And these are elimination, that's physically removing the hazard, substitution, so replace the hazard, engineering controls, so we isolate people from the hazard, administrative controls, so we change the way people work, or personal protective equipment. Now, the idea behind this hierarchy is that the control measures at the top of the graphic, they are potentially more effective and protective than those at the bottom. However, these are also difficult to implement in the existing processes unless there is re-engineering of workplaces, which brings us to engineering controls. Now, these engineering controls are favored over the administrative and personal protective equipment, and they may be difficult or more costly to implement at the initial startup period, but they are perhaps more effective and cost effective in the longer term. Then we come on to the administrative controls and use of personal protective equipment. These are frequently used with existing processes where these hazards are not particularly well controlled. Now, they may be relatively inexpensive to establish, but over longer term, they can be quite costly to implement and sustain, and also may be less effective and require significant efforts by the workers to use them correctly. So I'm now going to focus on measures in healthcare setting. I will not go into the details of the infection prevention and control measures, or indeed the use of personal protective equipment in clinical settings, but I will cover the key principles of planning and risk assessment and give an overview of those measures and also signpost to certain useful references. So in terms of planning and preparedness, what do health facilities need to think of? Now, even before the pandemic happened, countries are constantly assessing their levels of preparedness under the international health regulation. And that's what my day job involves, working with selected countries to review their IHR core capacities and help improve their systems for infectious disease prevention and control. As the pandemic started to evolve globally, all countries have had to rapidly assess their preparedness as there were lots of unknowns about the virus. Preparedness at health facility level involves assessment and consideration of key different areas of planning and implementation. And that's assessment of the current capabilities at the facility level, assessment of the workforce and occupational health issues, reviewing practices, how can they sort of implement social distancing where it is possible in those facilities, working in multidisciplinary teams to plan and make sure there are measures in place such as isolation, segregation, triage, defining the engineering, administrative, and personal protective equipment for staff, and alternative arrangements. So what do we do for long-term conditions, for chronic conditions? So just very briefly, in terms of principles, I wanted to highlight that there are two basic sort of principles. There are standard infection control precautions, and there are transmission-based precautions. The standard precautions are basic infection prevention and control measures to reduce the risk of transmission of infectious agents, both from recognized and unrecognized sources. And transmission-based precautions apply when the above, that's the standard infection prevention precautions, are not sufficient to prevent cross-infection when we have a known or suspected infectious agent. So very briefly, touching on the measures in healthcare settings, again, going back to the hierarchy of controls that I showed you earlier. So limiting the transmission of COVID-19 in healthcare settings requires a range of infection prevention and control measures that we can consider against that hierarchy of controls. And these are engineering controls, so having appropriate air handling systems, isolation facilities, improving the ventilation and physical barriers. There are administrative controls such as adequate staffing, having policies that reduce exposure, immediate triage of suspected cases, staff sickness monitoring, providing the correct PPE, providing staff training on use of PPE. Also, the third thing is safe working practices. So review our practices in the health facilities, monitor adherence to IPC practices. Our people, our staff adhering to appropriate hand washing between patients? What are the cleaning practices? How are we communicating this with staff as well as to visitors? And lastly, the personal protective equipment based on the hazard. So those personal protective equipments, they need to be properly fitted, worn, and they need to be disposed of according to the current national guidelines. And I wanted to just signpost you to a UK resource on infection prevention and control and the use of PPE when there is sustained transmission. This covers different settings. I'm not going to go into the details. The advice will vary by country. So again, you need to make sure that those the appropriate advice, taking into account local transmission and the health system, is adhered to. So I will swiftly move on to the measures in the workplace and industry. This is an interesting slide, and what it highlights is that the public health risk and the economic reality, it varies widely as we consider the restart of economy globally. So here you can see at the top the different pandemic phases, from active growth to when we may be in a post-vaccine, post-herd immunity phase. And as we progress through each phase, you can see the public health risk diminishing. Now, there is variation in how policies on easing the lockdown have been developed, with some countries reopening soon after the transmission has plateaued, whereas some countries are still taking a more cautious approach and waiting for significant decline. Other considerations when we're looking at phased return, to workplaces, there are 4 key considerations, and basically that covers adapt. So we all need to consider what's the need of the future. How is work going to change, and what will be the needs in terms of our future sort of deliverables in a new normal? We need to accelerate. We need to think of smarter ways, alternative forms of working. We are all already heavily sort of working from home, so remote working is becoming the norm. We need to be innovative. We need to craft sort of and see how we can implement new, safer working practices and processes. And lastly, we need to give enough time to consider planning and determining the workforce re-entry and how we can protect the most vulnerable of our workforces getting back to work. So again, going back to the hierarchy of controls, and it's interesting to map the workforce journey and how to consider the transition when we are looking at developing advice for workforce to get back into work. And again, mapping these hierarchy of controls against the different phases of return, phases of the workforce journey, right from pre-entry, so getting back to the workplace, to travel to work. What do we need to consider at work? What changes, what engineering measures, what administrative controls we need to put in place? How do we handle common workplaces? How do we handle those shared areas in the workplace? And what do we do if there's an infection at workplace? What are the guidelines that the employers need to follow? So it's very important to consider all of these against the hierarchy of control measures. The key is to plan and prepare our work environments to have robust plans and to communicate them clearly with our employees. And just to finish off in terms of the workplace environments, I'm not going to go into the details of this illustration, but this shows a sample journey in an office environment, as I showed in different phases from pre-entry to at work, common spaces, etc. It does highlight the issues we noted earlier and how it will now impact the new normal at workplaces in future. And again, to highlight some resources here, there are some guidelines that the UK government has published on getting the Brits safely back to work, working safely during coronavirus. So there are several documents that have been produced to different industries. And again, various governments in different countries will be working to develop country-specific guidelines. So towards the end of my presentation, I just wanted to make sure that we also think about educational settings, and particularly with the focus on schools and mainstream schools. And again, going back to the hierarchy of control and how these should be considered when planning safer return to schools. So what do we need to think of in terms of infection prevention and control measures in educational settings? Now, again, this is a busy slide. I'm not going to read everything on the slide, but just to highlight the 5 key areas. risk assessment and health and safety assessments in terms of how we will rearrange the school environments, adapting the environment both for the teaching and non-teaching sort of environment within the school. So maybe considering smaller class sizes, maybe considering not having the common break times for everybody together, one-way circulation within the school. How can we use outdoor spaces effectively? And it's important. The third thing is the communication with everybody who is related to the school, staff, parents, pupils. What do they need to do and what actions they need to take? And infection prevention measures, of course, very important, again, to reinforce the hand hygiene, personal hygiene sort of measures in school, and to highlight that PP is not routinely used in schools unless that's needed for somebody who is already, required to wear it as part of their routine care. And this will be perhaps extremely sort of people who have, other comorbidities or learning disabilities. And lastly, transport arrangements. It's really important to consider practicalities in terms of how parents will be dropping children to school, not crowding the common areas within, the gates near the school. So all of these measures really need to be carefully considered before school authorities, the governments can start to get kids back to school. And finally, measures for public transport operators, because as the economy start to open up, people will be starting to go out and will need to use public transport. So what are the measures and considerations for public transport operators? Now these, again, similarly going back to the hierarchy of controls, social distancing, face covering in enclosed spaces where we can't adhere to social distancing, workforce planning. So that includes also how to make sure that the workforce is educated and the travel operators are aware of what they need to do and what they should be aware of. Queues and protecting the passenger flows so that we are avoiding the crowding at any one place at any one point in time, having one-way systems, perhaps if possible avoiding face-to-face seating and supporting the vulnerable populations if they are to travel. What to do in emergency incidents, because there'll be overcrowding. So how do we handle that if there is an emergency incident? The advice related to cleaning of the transport vehicles, etc. Good ventilation and communication and awareness raising. So I just wanted to show this. At the very beginning, we saw the dot map globally, how the burden of infection of COVID-19 is spread across the world. And what you can see here is the global networks. And we know that, strong collaboration is happening across various countries globally. And this just highlights and illustrates that collaboration. So Chinese and Australian researchers made the COVID-19 genome freely available. That speeded up the vaccine hunt. So collaboration, openness is really most important for developing countries who might lack comprehensive research facilities and structures. So really, to end in summary, addressing the global challenges in vastly different local contexts require the combination of cutting-edge scientific capabilities with detailed local knowledge. And to me, this is the art in the science. And collaboration is at the heart of global science. We learn more and faster together. And really, the pandemic is underscoring the critical role of the international collaboration on frontiers of science and technology. So that's what I would like to end my presentation with. Thank you for listening.
Thank you, Dr. Inamdar, for an excellent lecture. It's an expansive field of discussing about protection and prevention from COVID, and you have done an excellent job in 30 minutes. So thank you so much. You described, in a way, a new normal for a re-engineered planet we call planet Earth. So it can begin from individual homes to communities to cities and nations and across the international flights and transports and schools. And it seems like once we are through with the public health containments and with this epidemic, which might have its own time lag, we are probably up for a very, very new designed globe, which will be then, in that case, no touch, enough physical space for everybody, and then our nose and mouth becomes the new private parts of a human being. So in that case, I think I'm sure there are a lot of questions coming in. What we are going actually planning to do is for Dr. Daniele and yourself, we are doing a question answer session for 15 minutes. And then we have the AYUSH consultant who will talk about prophylaxis using the registered Indian endorsed alternate systems of medicine, and whether they can be useful in terms of prophylaxis against COVID. The world was caught unawares. The whole world, even the developed and developing countries, all are short of beds for in the hospitals for care of infected people. So the world is caught unawares with suddenly the COVID epidemic or pandemic. Yeah, there's a question that has come in for Dr. Inamdar. The question is the question is about the domestic household helps.
Thank you, Dr. Hira, and thank you for the question. And indeed, um, the what advice and support we give for the informal care sector has been a challenge everywhere globally. And I think we have to recognize that the workers in this sector fall in between the loops because they're not like it's not an organized sector, and particularly as you give the example of work, domestic help and domestic workers in Asia. Certainly, it's one of the biggest unorganized sectors. I think a few thoughts, and certainly we don't have like all the answers, but as much as possible, if we can support our, the workers who have actually over the years, many people have workers who they have, relationships and work, and support families and see children growing up for years. So it's as employers in that sense, we really need to support them, making sure like I know examples where people have continued to pay them salaries when they were still not working and in lockdown. And perhaps as we start to consider the ease of the lockdown, making sure again they are well supported, they are educated, and made aware about what precautions, actions they must take, and how we can start to operate in that new normal. Even within the home setting, making them aware of the symptoms and to immediately sort of alert the households if they are symptomatic. I think there are very simple practical things that perhaps we can all consider, and I think there are no right or wrong answers here. And as I mentioned, the thing about craft and innovation, and I think we have to see our local context and how we can make sure that we protect, we support, as well as we make sure that these people can ease back into their working practices and get back their employment. And at the end of the day, it's about human relationships, isn't it? It's not like they are employee relationships, but as a human being, as we said, as an individual, it's our collective responsibility to support others, especially those who are perhaps at a more disadvantaged position. So taking some practical steps to follow, like the measures to protect yourself and the individuals, supporting them, not discriminating, giving them the right advice, and perhaps making work arrangements such that there can be that possibility of keeping that safe distance and minimizing any contact with other individuals. I think that's what comes to mind.
Dr. Inamdar, a quick question for COVID protection at workplace. Are they going to be, you think, are like firefight regulations in the buildings? So there will be regulations like of similar nature against COVID.
As I mentioned in terms of like my talk on the workplaces, we definitely have to think of a new normal. We definitely have to think of how we can rearrange the workspace environment so that we can, until the time that we need to maintain the social distancing measures, we have those measures in place. What is it that we need to think of in terms of different way of working, the working patterns? Is it that we arrange shift working, and so that we minimize too many people in the actual work setting at any point in time? Do we actually need everybody in the workspace physically, or can we actually be more flexible, and which jobs can be carried out safely, easily, remotely? We need to prioritize that. And I think definitely there's a need, as you mentioned about the fire safety regulations. So most workplaces, big workplaces, have fire drills, for example, as well as policies. They have what we call fire wardens. So there may be somebody like that nominated, working with the business operators and the managers in the workplace to um, look at business continuity arrangements, just reviewing, as we say, the whole risk assessment and health and safety assessment and at work. And I think every country has their own health and safety, occupational health regulations. And I think there needs to be a multi-pronged approach of like national level, perhaps a steer and guidance on those health and safety, occupational health assessments, and then guidance for individual work, employers in different industries, because like every industry is different, every workplace will have different challenges. So there needs to be a framework for countries against which they can start to, then individual employers can start to sort of plan what they need to do and change in terms of making work places safer for employees.
Thank you. It sets a platform for people to start thinking what next as we gradually go into opening up the lockdowns. Thank you. I think our time is gone up. So thank you, Dr. Daniele, Dr. Inamdar. Our third speaker is Dr. Shivangi Pawar from India.
So I would like to start my presentation by first defining what is AYUSH. So as most of us must be already aware that AYUSH is comprised of various medical systems that are being practiced in India, such as Ayurveda, Yoga, Naturopathy, Unani, Siddha, and homeopathy. So all these systems of medicines have a holistic approach on health, diseases, and treatment. These systems are based on definite medical philosophies. They represent a way of healthy living with established concepts on prevention of diseases and promotion of health. So today I will emphasize more on homeopathy's system of medicine with reference to prevention of epidemic diseases. I would like to play a small video in which I have briefly mentioned the role of homeopathy during epidemics.
Hello everyone, I'm Dr. Shivangi. I'm a consulting homeopath, and in this video I'll be discussing homeopathy's efficacy in treatment and prevention of coronavirus. If we look back into history, homeopathy has a very good track record with treating epidemics and infectious diseases worldwide. The use of homeoprophylaxis right from the time of Dr. Samuel Hahnemann in 1798 to the present day is widely evidenced throughout the homeopathic literature. Homeopathy has successfully reduced the mortality rate in several recorded incidents of epidemics, be it scarlet fever of 1799, typhus fever, epidemic of cholera, yellow fever, diphtheria, and most relevant to our present circumstances, the success of homeopathy in treating the Spanish flu of 1918. Also not to forget the massive and highly successful homeoprophylaxis intervention in Cuba for leptospirosis in 2007. So the epidemiological evidence clearly shows that homeopathy discloses a very consistent and strong prophylactic and therapeutic effect, while at the same time it offers safe, cost-effective, and clinically viable alternatives to conventional medicine for prevention and treatment of patients with infectious diseases. Homeoprophylaxis intends to instill a natural immunity by stimulating the inherent immune system so that when we are exposed to the disease, our vital force is primed to react with the mild or asymptomatic version of that disease. Many homeopathic practitioners who have successfully treated coronavirus cases claim that the patient who have been either exclusively treated with homeopathy or alongside conventional therapy recovered faster, used fewer medications, and had a better prognosis. However, different homeopathic remedies might be needed in different symptomatology.
We have provided about 76.72 lakh doses of the homeopathy medicine for boosting the immunity arsenicum album of 30 potency, and as many as 76 lakh 72,000 people have availed of this. As many as 2,625 people chose to go for homeopathy treatment, which was administered to them. It's very interesting to note that out of all these people, none of them tested positive. It was only 11 who tested positive.
To the Pune police, we sent 9,000 vials for 45,000 people. The rural police, the PCMC police, the railway police. So effectively what is happening is that over 300,000 people in Pune have gratefully taken Camphor 1M in the hope that it will protect them. We have given this remedy to 300,000 people. Nobody has come back to us saying that after taking this remedy, I have now developed symptoms.
Now, moving on to why homeopathy is proving to be so effective when it comes to treating this epidemic. Unlike bacteria, viruses depend upon the living cells to survive and replicate. They also mutate very quickly, resulting in the viral pandemics which are difficult to manage, like this one. When we encounter a viral infection, our body's immune defense system intervenes with its innate response. In many cases, this initial response, this initial activity of the immune system, is sufficient to kill the virus. Even in coronavirus infection, it's seen that a robust immune response across different cell types is associated with quick clinical recovery, similar to what we see in influenza. So far, the majority of COVID-19 cases, that's around 80% approx, are mild cases, mild to moderate cases. And most of these patients with mild infection do not progress into severe form and can recover with just the help of their own immune system. Now, remaining 18 to 20% who are at the higher risk of developing severe complications and death are elderly people, or those who are predominantly affected by an underlying chronic medical condition. They are the ones who have a compromised immunity. Even an overactive immune response is thought to play a role in disease progression of the sickest COVID-19 patients. So, in order to recover, it is vital that we have a healthy immune system that provides the body with modalities to fight back when it is under attack. And in order to promote a healthy immune system and optimum immune system, we can definitely rely on homeopathy. Homeopathic medicines have been shown to significantly lower the risk of developing infections when we use them prophylactically before viral exposures. So they have been found to be effective in numerous public health situations treating a range of infectious diseases. Homeopathy is a system of medicine which has proved its efficacy in treating epidemics without damaging the immune system. So by adding homeopathy as adjunct to conventional medicine, patients, clinicians, society as a whole, and even conventional medicine has nothing to lose. But on the contrary, they have everything to gain if we obtain the same success as the ones that have already been obtained in the past. Thank you.
So homeopathy does not rely on diagnosis. It is a symptom-specific system. So though the virus strain is novel and unpredictable, homeopathic remedies are based on evolving symptomatology exhibited by various patients across the globe. So homeopathy works by understanding these symptoms, and it helps in improving or building the immune system. And it can be instilled in patients of all ages. There are no side effects. These ultra highly diluted homeopathic medicines are absolutely safe for children, for pregnant ladies, for elderly people, even for people who are already suffering from any other chronic illness. They can also take these homeopathic remedies alongside the allopathic medications. I'm glad that Global COVID Network and Dr. Hira gave me this opportunity to present the hope that homeopathy provides as a prophylaxis in order to prevent infectious diseases. Yeah, thank you.
Thank you, Dr. Shivangi, for your excellent presentation.
Thank you
It's
so much.
forward-looking, essentially, forward-looking with some anecdotal uh, uh, community leaders endorsing the homeopathy prophylactic doses for 3 days and 6 days across. So it is open for questions. Are there any questions from the panelists or from the audience?
Wishing to answer your previous question about the usage of hydroxychloroquine in Italy, either for prophylactic or treatment in COVID. Yes. Yes, based on the publication on a newspaper a couple of months ago, Italy, yes, has started using hydroxychloroquine against coronavirus. Anyway, things are changed now because the Italian drug agency, the national Italian drug agency AIFA, stresses that hydroxychloroquine should be employed either for treatment or prophylactic purposes only within controlled clinical trials, because there are no final conclusions regarding its safety, efficacy. On the other hand, a very recent study from Lancet state that on a large population investigated, that there are more harm than benefit by using this drug. On this wavelength, WHO yesterday has withdrawn from any involvement of the agency into current clinical studies using the drug. So while conclusive data are not available to date, I know, however, that doctors in Italy or sanitary staff at large are using this drug mainly for prophylactic purposes, even though there is no consensus about. So I think while the results of clinical trials are not available to date, I think this use against COVID is not supported by any confirmed date. So I think this use should be avoided at only rests within controlled clinical trials only.
Very true. Some countries, including India, have used hydroxychloroquine both for treatment as well as the treatment protocols, as well as also very large prophylactic samples, thinking that it will possibly have reduced transmission rates of COVID, as well as also it probably will manifest as less symptomatic and less severe disease. But what WHO stand it took yesterday has kind of brought the world to wake up again. It's obviously that everybody wants to look for some solution, some prophylaxis where billions of people are now vulnerable to this infection. Camila, it's back to you. Do you have any housekeeping announcements?
Thank you so much, panelists and attendees. The session was extremely insightful. I'll just share a couple of resources that you can explore through the week. The Global COVID-19 Network has a microsite, which I'm sharing with you through my screen right now, which is a resource for all of our past webinar recordings and learnings. So do give this a scroll. You can access all of our previous recordings and names of our panelists. I will share the link with you on the chat box. So do go through it. Do check out our social media. We have a lot of communication materials and a lot of interesting reads which you can explore on the discussions that take place during sessions. So yes, do go through it.
Okay, thank you, Camilla. And one last point is the next week's webinar, the 6th webinar, will be held on the 2nd of June at the same time, being a Tuesday,